So today I'll be talking about the role of immunotherapy in triple negative breast cancer. As we all know that the breast cancer is the most frequent diagnosed cancer in women and ranked second amongst all the causes for cancer related death in women. So now many researchers are being going on providing the improving in the clinical outcome in the breast cancers. Now we also have screening, diagnostic and therapeutic strategy engaged in breast cancer management. However, poor prognosis in triple negative breast cancer and drug resistance presents major inhibition, which are also current challenges for containing the disease. So coming to the classification based on histology and molecular markers. So breast cancer can be divided into in situ carcinoma and the invasive carcinoma. Today we'll be talking about invasive carcinoma. Based on histology, there are multiple types: tubular, ductal, lobular, invasive lobular, infiltrating ductal, mucinous, medullary, and uncommon one, papillary. Based on molecular classification, we have luminal A, luminal B, HER2 enriched, and basal cell, basal-like carcinoma. So these are the histological slides. Now coming to the prevalence of the breast cancer based on histology. So most common being invasive ductal carcinoma, ranging between 65 to 80%, followed by invasive lobular carcinoma, followed by tubulolobular, then invasive cribriform carcinoma, medullary, and some of the mentioned carcinomas are the rare ones. So in basal, like we have ERPR negative, HER2 negative, means all the targets are negative. In HER2 positive, we have ERPR negative and HER2 positive. Normal basal like breast, like in which we see either ER is positive or negative with PR unknown and HER2 negative. Luminal is having ER positive or negative, similarly with PR, and the HER2 is negative or positive. Basal like and the HER2 positive are having high proliferation rate. The lowest one is the normal breast like. Now coming to the incidence of TNBC, TNBC accounts for the 10 to 20% of the breast cancer worldwide, but in Indian scenario, it is a bit high. It ranges between 27 to 34%. And half of them, they present in advanced and the metastatic stage. The minimum age of presentation is 22 years, the maximum 75 years. 60% of the patients are less than 50 years. So as we all know that TNBC like expression of ERPR and the HER2. Now coming to the common characteristics of TNBC tumors compared to other breast cancer tumors. So they are having more likely to have great histology, large tumors at the time of diagnosis, high mortality rates, more aggressive disease, and higher rates of distant recurrence. So it has significant unmet medical needs. Coming to clinical outlook for patients with TNBC, when we compare to other breast cancer, there is higher risk of spread outside the breast within first 5 years of diagnosis compared to other breast cancer. Mean time for distant recurrence is also lower. Decrease in 5-year survival with the standard therapy versus other breast cancer is also lower. Median survival for women with metastatic TNBC is less than 1 year, and amongst all patients almost all patients die from the disease despite having aggressive systemic chemotherapy options. So these are the survival rates based on the stage of the disease. As we can see, whether it is localized or advanced stage 4, clearly the TNBC has lower survival. And the likelihood of distant recurrence is high in TNBC patients. We can see the graph, the TNBC is constantly lower than the other breast cancers. So definitely we have a very high unmet clinical needs. OS is worse than in TNBC patient. Recurrence rate is also high. We don't have other option other than chemotherapy, and the disease being aggressive, heterogeneous disease that needs further segmentation into treatable subtypes. Now coming to the very characteristic feature of TNBC, that is T cell infiltration in TNBC compared to the breast cancer. You can clearly see that the TNBC has the highest T cell infiltration. So the high mutation rate of TNBC may produce tumor-specific antigens that induces immune response by which there is infiltration of T cells. So if we see, if there is T cell infiltration in TNBC is associated with prognosis or not. So they've done some research. For each 10% increase in the level of stromal tumor infiltrating T cell, there is 19% reduction in the risk of death, 13 to 18% risk of distant recurrence, reduction in risk of recurrence or death by 14%. So PDL1 expressed on TNBC can suppress the immune response, is therefore a potential therapeutic target. So the therapy which targets the PDL1 or PD1 pathway may therefore enhance the immune response. So this is showing the TCGA data that the higher PDL1 mRNA expression in breast tissue specimen from the patient with TNBC compared to the non-TNBC. So this diagram is showing tumor microenvironment. It is showing how PDL1 activation leads to deactivation of the T cells. So by targeting the PDL1, we can actually promote the T cell activity and by killing the tumor cells. So what is the current management of TNBC? As we all know that if it is localized primary breast cancer, we have adjuvant chemotherapy after surgery or neoadjuvant chemotherapy before surgery. And then there are some options for the post-neoadjuvant chemotherapy also. But if we come to the metastatic TNBC, in first line, we have Texans and the platinum-based combination. If we talk about the second line, there are capecitabine, then again platinum-based combination, eribulin. If we talk about third line, then we have only eribulin and the best supportive care. So mostly we have seen that we have anthracycline, Texans, and platinums. And to choose between single agent or combination, we see some of the parameters, including performance status, risk of adverse events, prior chemotherapy regimens, disease burden, and patient preferences must be considered. So combination therapy is shown to have improved response, however, associated with more adverse events. So these are the survival outcomes with the recommended treatment regimen in metastatic triple-negative breast cancers. We can see the OS and PFS. So to summarize this, metastatic TNBC is currently incurable. The mainstay of treatment is chemotherapy, usually single agent therapy. Double agent can be used based on the certain parameters. Now coming to the role of immunotherapy in triple-negative breast cancer, this is the first trial, I am patient 130 trial. Coming to the design and the results, it was phase 3 Tecentric study in metastatic triple-negative breast cancer. The key eligibility criteria were metastatic or inoperable locally advanced TNBC, no prior therapy for advanced TNBC, prior chemotherapy in curative setting were included. Including Texan, allowed if treatment-free interval is more than 1 year. ECOG PS was 0 to 1 and any PDL1 status were included. So they further stratified based on the prior Texan use, liver metastases are there or not, and PDL1 status. They divided into 2 arms, Tecentric plus NEPPAC arm and the placebo plus nab-paclitaxel arm. The primary endpoints were the PFS and the OS in the intent to treat population and the PDL1 positive population. Key secondary endpoints were the overall response rate, duration of the response, and the safety. So the choice of nab-paclitaxel, as we all know that it has a lesser risk of having hypersensitivity reaction. But if we see the overall data, there is no difference between using nab-pac or paclitaxel. So we can combine with either nab-paclitaxel or paclitaxel. So this is the study design. So they randomized 902 patients. They divided into 2 groups, Tecentric plus nab-pac, then the placebo plus nab-pac arm. On study, there were 246 in arm 1 and 219 in arm 2. And they did survival follow-up in 182 patients in arm 1 and 166 patients in arm 2. So coming to the baseline characteristics, so they were generally balanced. The median age was 55. Almost all patients were female in placebo plus nab-pac, 99 in Tecentric plus nab-pac arm. ECOG PS was 0 to 1. Prior use of adjuvant or neoadjuvant treatment was prior Taxane or anthracyclines. The most common site of the metastasis was lung, followed by bone, liver, and brain. PDL1 positivity was present in 41% in both the arms. Primary PFS analysis in intent to treat population, as we can see on our left, that the PFS is 5.5 months in placebo plus NAPAC arm versus 7.2 months with hazard ratio of 0.08 in atezolizumab plus NAPAC arm. 1.7 months significant median PFS benefit was observed with the addition of Tecentriq to NAPAC arm. Based on PD-L1 status, we can clearly see that the effect was more in the patient who has PD-L1 positivity. The HR was 0.62 in PD-L1 positive patient versus 0.9 near to 1 in PD-L1 negative patients. So the effect of atezolizumab was more pronounced in the patient with PD-L1 positivity. Coming to the interim OS analysis in intent to treat population, we can see both the curves are touching each other. So there was the median OS was 17.6 months in A placebo plus NAPAC arm compared to 21.3 months in atezolizumab plus NAPAC arm. Though it was not statistically significant at this first interim analysis, but it gave numerically 3.7 month median OS benefit. This is OS analysis by PD-L1 status. Similarly, as we have seen in PFS, here also the hazard ratio for PD-L1 positive patient, it is 0.062 and it is 1.02 in PD-L1 negative patients. In subgroup analysis based on liver metastasis, prior taxane use, PD-L1 status, we can see 3 of them are on the left of the center line. The PFS benefit was primarily seen in PD-L1 positivity. This is the response. Definitely the response was more in PD-L1 positive, like around 60% compared to the 43% in NAPAC plus placebo arm. Now coming to the adverse event of special interest, we can see any grade of side effects were more or less same in both the arms, 57% in Tecentriq plus NAPAC versus 42% in placebo plus NAPAC arm. The hepatitis rate was balanced. All hypothyroidism events were only of grade 1, 2. None led to treatment discontinuation. And pneumonitis was also infrequent. Common side effects were alopecia, fatigue, nausea, diarrhea, cytopenias, headache, neuropathy, and they were balanced in both the arms. Most common side effects. So the higher proportion of patients in the Tecentriq plus NAPAC arm then in the placebo plus NAPAC arm, clearly seen 23% versus 18%, but the difference was not significant and all were manageable. Now coming to the updated efficacy and safety result from second interim analysis. In second interim analysis, we can see the OS, it is 42% versus 39% at 2 years. And the comparison of OS in PD-L1 positive and negative patient, we can see the effect was more in PD-L1 positive patients. This is updated safety analysis. They were well balanced and it can be used safely. So what are the key learning points and clinical implications? IMpatient 130 is the first phase 3 study to demonstrate the benefit of cancer immunotherapy in metastatic triple negative breast cancer. The benefit risk profile of Tecentriq plus NAPAC supports a change in practice in first-line treatment of triple negative breast cancer. Then we have to see if the patient is PD-L1 positive, the benefit is certainly there, but not in PD-L1 negative patient. To summarize, as we all know that the high incidence of TNBC in India, TNBC is associated with high relapse rate and overall poor prognosis. Treatment options are also limited and mostly in form of conventional chemotherapy only. No new adverse events were reported. A clinical meaningful 25 months median OS benefit was observed with the addition of Tecentriq in the PD-L1 positive patient. IMpatient 130 is the first trial, as we have seen, which showed the effect of the cancer immunotherapy in these patients. So based on the interim analysis, though US FDA has withdrawn the indication of the Tecentriq with NAPAC in TNBC indication, but if our patient has exhausted all the option and the patient has PD-L1 positivity, then definitely it is an option. Thank you. Thank you all.
Thank you, Dr. Anu, for this elaborated talk on TNBC management. And I thank the organizer for getting me involved in this wonderful conference.